Good evening, doctors. My name is Rahul Desai, and I hereby welcome you all to today's module of 52 Weeks of Diabetes Essentials Season 2. Dear viewers, these online modules are an educational initiative from Menazal Zero and in memory of late Dr. K.K. Agarwal sir. India leads the world with largest number of diabetic patients and is often referred to as the diabetes capital of the world. Diabetic dyslipidemia in India is one of the main causes of coronary artery disease mortality, and therefore, today's topic, that is dyslipidemia and diabetes, forms an important milestone in our journey of 52 weeks of diabetes essentials. Although diabetes continues to be a major lifestyle condition in India, there is a lack of studies in India on whether dyslipidemia in Indian diabetics is being adequately controlled. And therefore, before I hand over the platform to Dr. Kalra sir to take us through today's event will address on newer drugs in diabetes, which is very essential looking into the number of population and
Good evening, friends, and welcome to this edition of Diabetes Essentials. Thank you for being with us every day, every week, and thank you for being with us in our journey towards improving diabetes care in our country. We acknowledge the enthusiastic participation of everybody, and especially when we get so many questions, that actually gives me a lot of energy, a lot of enthusiasm to work more and more for Diabetes Essentials. Today, we'll talk about something that is supposedly easy to handle, but something that we tend to neglect. All of us tend to neglect this in practice, including me. So today we'll be talking about dyslipidemia and diabetes. Now we all know the story of this girl who said, mirror, mirror on the wall, who's the fairest of them all? In diabetes, we can ask the question, mirror, mirror on the wall, which is the easiest to treat all of them, of them all? Which is the easiest to manage, to intervene in, so that we can improve cardiovascular outcomes? The moment we ask the question, you know the answer. We have four choices. Is it easy to reduce HbA1c? Is it relatively easy to reduce body weight, or blood pressure, or lipids? And now I'm sure there'll be 100% agreement with amongst all of us that managing weight is the toughest, followed perhaps by reducing HbA1c. It is relatively easy to reduce blood pressure and lipids. And within these two also, most of us would say that reducing lipids is easier than reducing blood pressure. We would also agree that even though reducing lipids is easier, we tend to give minimum attention to the lipid numbers. Many times when patient comes in with bad lipids, we just tend to brush them under the carpet. And we forget that just a tiny intervention from our side, telling the patient to focus on lipid levels, telling the patient to take the right medicine, a lipid-lowering drug, can actually help improve long-term outcomes in persons with diabetes. So mirror, mirror on the wall, which is the easiest to treat of them all? The answer is dyslipidemia. And let's see how we can actually do that. We call ourselves the diabetes capital of the world. And we are also the coronary artery disease capital of the world. We are the NCD mortality capital of the world. But it is not a matter of pride for us. Actually, we should be aiming to be the diabetes care capital of the world. But we can do that only if we bring down all these numbers: HbA1c, body weight, cholesterol, and blood pressure. And if we look at cholesterol, more than half of our patients are not at LDL goal. That is why there is a residual risk for cardiovascular disease. What is the kind of diabetic dyslipidemia that we see in Indians? Predominantly, we see more triglycerides. So most of your patients will have triglycerides and also a reduced HDL. So the good HDL, which should be high, becomes low. The free fatty acids, the triglycerides, the VLDL, very low density lipoprotein, which should be very low, that actually becomes high. So it's opposite. This can be directly due to poor glycemic control. It can also be due to just aging or the wrong diet. LDL also increases in persons with diabetes. And even if the LDL is normal, you will find that they have more of small, dense LDL particles, more of ApoB. So these small, dense LDL particles are more atherogenic. So overall, persons with diabetes living in India will have a dyslipidemic profile. How do we explain to the patient? In simple words, what I tell my patient is, if you eat too much of fat, the fat cells will not be able to store it. There is a limit to how much fat the fat cells can store. And especially if the person has insulin resistance. If there is insulin resistance, insulin works like a key. The key will not be able to open the locks in the fat cells. So fat will not be able to enter them. So it will remain outside in the circulation. That is free fatty acids. It circulates in the blood. These free fatty acids get converted into triglycerides, three glycerides together. These triglycerides act like a poison upon the endothelium of the body. So that is lipotoxicity. In the liver, the LDL is produced, low density lipoprotein is produced also in the liver. And if the liver is insulin resistant, then more of LDL will be produced. HDL reduces because more of VLDL is produced, relatively less of HDL is produced in the liver. And all this situation worsens with poor glucose control and also with insulin resistance. If there is insulin resistance or insulin deficiency, lipoprotein lipase will not be able to work. When lipoprotein lipase is not able to work, then the triglycerides cannot be broken down. If the triglycerides cannot be broken down and they cannot be cleared, this will happen in inflammation. Then these triglycerides and also the free fatty acids, they act like a poison, like we said. And this is also partly due to inflammation, due to the pro-inflammatory cytokines. In obese people, the bad cytokines, pro-inflammatory cytokines are increased, and also the good ones, the adipokines, like adiponectin, they are reduced. This is what happens in diabetes. What happens when you treat diabetes? Now, this subject is known as lipocrinology. What happens when you connect the dots between lipid levels and endocrine function or glycemic function? So sulfonylureas do not have any effect, neither does insulin, but you will find that metformin, DPP-4 inhibitors, GLP-1 receptor analogs, acarbose, pioglitazone, and bromocriptine, they all reduce triglycerides. So most of the drugs, except for sulfonylurea and insulin, will reduce triglycerides. You will find that SGLT2 inhibitors paradoxically may increase LDL cholesterol, but colecivilam, which is a drug that is usually used to reduce HDL, can be used in diabetes as well. It is approved in America as an anti-diabetic drug. This reduces LDL but increases triglycerides, may increase triglycerides. Pioglitazone is a paradox. Pioglitazone reduces triglycerides, increases HDL. It is the only drug to show an increase in HDL. There is a small increase in LDL, but when that was studied further, they found out that the small dense LDL actually came down. So the atherogenic LDL came down. So a question asked today by Dr. Gauri Shankar is, any drug which increases HDL? The answer is number one, pioglitazone. Number two, niacin to some extent, but that is not used because it has not shown any improvement in long-term outcomes. So we've talked about diabetes and about diabetes lowering drugs, glucose lowering drugs. But these glucose lowering drugs alone are not enough to normalize lipid levels. So usually you will need a lipid lowering drug. The drug of choice is statins. Certainly it is statin. If triglycerides are a concern, you will use fibrates. If diabetic retinopathy is a concern, you will use fibrates. If the patient does not respond to, or it is anticipated that the person will not achieve targets with maximally tolerated statin, then we can add bempedoic acid or we can substitute with bempedoic acid. Similarly for ezetimibe. And then other drugs are there, PCSK9 inhibitors. These are injectable drugs given twice a month. They are expensive. They are usually used in a disease called familial hypercholesterolemia, but you can use them in diabetic dyslipidemia as well. And also we have bile acid sequestrants. We've talked of monotherapy. You can also give combination therapy. Statin plus fibrate will be given in a patient with very bad triglyceride levels and also with diabetic retinopathy. Fibrates help in secondary prevention of diabetic retinopathy. Statin plus niacin is not indicated now because there is no benefit with niacin and it causes hot flashes. Statin plus ezetimibe, statin plus bempedoic acid will be used when statin alone is not sufficient. Same for statin plus PCSK9 inhibitor, but an extra indication for statin plus PCSK9 inhibitor is familial hypercholesterolemia. In some patients, you may wish to use omega-3 fatty acids and statins. And omega-3 fatty acids can be given in pregnancy and lactation as well. Now, we have seen what happens to lipid levels in diabetes. We've seen what happens to lipid levels when diabetes is treated. And we've looked at the drugs that are used for lipid lowering. But what does the ADA recommend? Now, primary prevention, this is important. Any person aged between 20 and 40 with additional risk factors, which can be family history of heart disease, smoking, obesity, hypertension, microalbuminuria, you may wish to initiate statin. Age 40 to 75, everybody should get statin, everybody with diabetes. Age above 75, we should give statin, but discuss with the patient about long-term risk. If patient has an expected short duration of life, then maybe statins will not suffice, will not be necessary. If patient is otherwise doing well and there is no other comorbid condition, then statins should be continued. We should also know that in geriatric diabetes, you just don't look at the number of age. You look at the overall health, the function, the frailty of the patient. If the patient is not frail, then we should continue giving statin therapy. You can also check the 10-year risk of cardiovascular disease. How do we do that? We check the Q risk 3 score. Capital Q, capital R, small isk, Q risk 3. Just type in Q risk 3. It will take you to a website which is from the United Kingdom. This is a multi-ethnic CV risk score. Just type in Indian ethnicity and type in everything else, all the other data, and you will get the 10-year risk of cardiovascular events, ESCVD events. If the 10-year risk is high, more than 10%, then you should give statin. If it is more than 20%, there's no harm in adding ezetimibe or bempedoic acid. Bempedoic acid is the better drug that we have available now. This is for primary prevention for people who have never had ASCVD in the past. For secondary prevention, everybody who has had an episode of ASCVD, then we will give high intensity statin plus aspirin up till the age of 75. And above 75, we should continue statin and think about aspirin. If the patient is at very high risk of recurrence, then try to bring the LDL down to 20. And you may wish to add ezetimibe, PCSK9 inhibitor, or bempedoic acid right at the very beginning. Do remember that lifestyle is important. Patients should go on a healthy diet. Physical activity is important. And the drugs, like we have said, statin is the first line. For second line in oral, we will choose ezetimibe or bempedoic acid. And if triglycerides are the major issue or retinopathy is the major issue, then we will choose fibrates. If it is familial hypercholesterolemia, then we prefer PCSK9 inhibitors. There are some downsides also. With some statins, except for pitavastatin, it is thought that the risk of new onset diabetes goes up. So you have to be careful. But overall, the risk-reward ratio is such that statins should be prescribed. Statins can be used in thin people as well. If you use bempedoic acid, if you add bempedoic acid actually reduces new onset diabetes. It is an anti-diabetogenic drug. So you can give statin and bempedoic acid together to achieve metabolic neutrality. Ezetimibe per se is metabolically neutral from a glycemic point of view. But let us say we use statin alone, we will find that LDL will come down, triglycerides may or may not come down, and there will be a slight increase in HDL cholesterol. How much reduction will we get? Let us look at the two drugs that we use often, most commonly in India, rosuvastatin and atorvastatin. Atorvastatin, 20 milligram, will bring about a 40% reduction in LDL. Atorvastatin 40 milligram and rosuvastatin 10 milligram will lead to a 48% reduction, a 50% reduction in LDL levels. And if we increase the dose, we give atorvastatin 80 or rosuvastatin 20 milligram, then we can expect a 54% reduction. If you go up to rosuvastatin 40 milligram, then you can expect a 60% reduction in LDL. So the baseline LDL, like supposing somebody's LDL is 150, you want to bring it down to below 100. So you need a 33% reduction in HbA1c. Then maybe we would be justified in starting atorvastatin 20 milligram. But if I want to bring it down to 70, maybe patients at very high risk of ASCVD, I want to bring it down from 150 to 70. That is roughly 50% reduction. Then I will need to give atorvastatin 40 milligram or rosuvastatin 10 or 20 milligram. So this is how you can use this chart to decide how much of dose to start. Statins are by far the strongest LDL lowering drugs. You can add ezetimibe or bempedoic acid or PCSK9 inhibitor, but statins have to be given unless they are contraindicated. If they are contraindicated or if you feel that LDL levels were very high, then we have already said fibrates can be used. Fibrate should be prescribed in the morning, statins in the evening. If you have an FDC, you can give it any time of the day, even morning will be fine. Bempedoic acid is a very good drug. It inhibits cholesterol biosynthesis and it can be used in the morning, 180 milligram once a day, in addition to maximally tolerated statin or as an alternative to statin if it is not tolerated at all. 180 milligram once a day in the morning would be the dose. Colecivilam is available in India, but it is quite expensive. I have not used it frequently. Ezetimibe is available. I have used it in the past, and it is glucose neutral, but actually it doesn't make too much of a difference on the LDL levels. So now that we have bempedoic acid, I use that more often instead of ezetimibe. Niacin was recommended earlier. It causes hot flash. It is not recommended for use now. How do we approach? Our primary approach will be the LDL level. So look at the threshold. Where are you starting from? Try to reduce it to 30 to 40 to 50 by 30, 40, 50%. Begin a statin. If after 6 weeks things don't come down, then either you increase the dose of statin or you might wish to add ezetimibe or bempedoic acid. If triglycerides are the major issue, then fibrate should be added. Once you have optimized LDL cholesterol, then the next step is to focus on non-HDL cholesterol. So try to bring that down. Do inform the patient that high triglyceride levels can predispose to pancreatitis and lifestyle is the best treatment. If patient has very bad diabetes, very poor control, then insulin would be a good drug. Insulin will bring down triglyceride levels in such patients. So this is what we were talking about today. But let's ask a question to see how well we've understood. A 32-year-old woman living with diabetes who is overweight has a triglyceride level more than 1000. TSH is normal. Kidney function is normal. The three common causes of secondary hypertriglyceridemia are hypothyroidism, uncontrolled diabetes, and renal dysfunction, renal failure. So she has diabetes, but there is no history of hypothyroidism. TSH is normal, and the kidney functions are normal. Family history is positive for diabetes and pancreatitis and premature CAD. So this is a high-risk patient now, and she's just 32. You advise her to follow a low-fat dietary diet, to exercise regularly, and to avoid alcohol. But the question is, do we need to give a medication? And if yes, which one should it be in this lady? A, high-dose rosuvastatin. B, nicotinic acid or niacin. C. Low dose atorvastatin. D. High dose fenofibrate. And E. Over the counter fish oil, omega 3 fatty acids. So let me ask again, a 32-year-old lady with triglycerides more than 1000, strong family history. Apart from diet, what else should she receive? High dose rosuvastatin, niacin, low dose atorvastatin, high dose fenofibrate, and over the counter fish oil. Let us revise again that there is a fixed dose for bempedoic acid, 180 milligram, a fixed dose for ezetimibe, 10 milligram, and a fixed dose also for PCSK9 inhibitors. It is just for statins that you have to change the dose. And we welcome very warmly Adab, Dr. Rabia Umair from Pakistan. Welcome and thanks for joining us. We have lots of questions coming in today. A few questions from Dr. Gauri Shankar Dharmaraj. Let me take them. Is it absolutely mandatory for all diabetic patients above 40 years to start statin, irrespective of HbA1c and other things? Yes. As primary prevention for ASCVD, we should do it. It is more important for people from South Asia because the risk of subclinical ASCVD, that means there are no symptoms, no signs, but if you do the imaging, you will find ASCVD. That is 55% in South Asian population. The World Health Organization has recently has given targets for 2030, for the year 2030, and they say that 60% of all patients above 40 with diabetes, 60% of all patients with diabetes above 40 should start statin. But 60 is not enough. We should try to go to 100. Suppose your patient is not very keen. Then what you do, you go on QRisk 3. You calculate the risk for your patient. The beauty of QRisk 3 is you can put in Bangladeshi, Pakistani, Indian, whatever ethnicity you are, and you will get the risk factor for your country. Of course, this is based on people from Bangladesh, Pakistan, India living in United Kingdom. But it is effective, very useful. And then you just show the patient that score. Your risk of getting a heart attack in the next 10 years is 3%. It is 30%. Is this acceptable to you? If the patient says yes, it is acceptable, fine. Stop the discussion. See, then you say, let's talk about it again when you come back next time. But please do share this data with your wife, with your husband, with your children. If the patient says, I'm really worried, you've given me an 11% risk of heart attack, this is too much for me. How can I bring it down? Then the answer is healthy diet, healthy exercise, healthy lifestyle, and statin. Even below 40, between 20 and 40, you can give statin if the lipid level is high. When to check lipid profile after starting statins? Usually 3 months after starting statins. In some people, we may do at 6 weeks if the patient is worried. If the LDL is low, if it has reached below 55, below 70, then you can reduce the dose. But if it is above 70, just keep the dose the same. In fact, if it is above level, you can increase the dose to double. If HDL is decreased, we do not have to give any separate drug. The best treatment for low HDL in South Asia would be a healthy diet with more of nuts and fruits. And if HbA1c decreases, certainly triglycerides come down. Triglycerides have direct correlation with HbA1c. LDL will not come down so much, but triglycerides will come down markedly if HbA1c comes down. What's your experience with ezetimibe? I have used a lot in the past. In addition to rosuvastatin or atorvastatin, when they were not effective in bringing down the HbA1c. And also, once a few years ago, I had got myositis. So then I used ezetimibe for some time. But it is not all that effective. The LDL levels do not come down markedly. Fibrate and rosuvastatin you can use together. Indications would be patients with very high triglycerides and statins, patients with diabetic retinopathy, where you want to prevent the worsening of diabetic retinopathy. These will be indications for statin plus fibrate. Do remember that when you give statin and fibrate together, the risk of myopathy can go up. Dr. Narinder Patel asks, phenofibrate and normal triglycerides. The answer is yes. There is a role to prevent diabetic retinopathy. It is approved in many countries. And also you will find that if patient has got severe neuropathy, then also phenofibrate can help. So as a desperate measure, you can add phenofibrate to patients with symptomatic neuropathy. Dr. Safat Khan asks, if triglycerides are low, any effect on diabetes and the heart, it is a beneficial effect. If triglycerides are low, there will be less toxicity, less endothelial toxicity, and there will be less complications of diabetes. Dr. Sanjeev Puri from Hoshiarpur says, any study between lipids and COVID-19? Yes, there is, sir, actually. Treatment of COVID-19 and dyslipidemia and diabetes. So now COVID-19 has been found to be a pro-ischemic condition, pro-anginal condition. People who have recovered from COVID-19, especially long COVID-19, have been found to have an increased risk of dyslipidemia and coronary artery disease. So if your patient had COVID-19 last year or the year before that, keep that patient on heightened surveillance for CVD. You don't need to send the patient for echo and TMT all the time, but you should do microalbuminuria, lipids, blood pressure. All these should be done regularly every 3 months. And if there is even a borderline dyslipidemia or microalbuminuria, that must be treated with appropriate drugs. One question from Dr. Girish is about saroglitazar, when to initiate. Can it be given along with statin? Yes, it can. It is a good drug to bring down lipids. The long-term outcome is not there. It is a good drug for lipids and for NAFLD. The indication as per label is diabetic dyslipidemia. The numbers come down markedly, but there is no long-term cardiovascular outcome trial. So when you give it, you can tell your patient that yes, the triglycerides will come down, that we can assure you. But if the patient says, is this beneficial for my heart in the long run, then we don't have data for that as of now. So question is from Dr. Vinay, very important question, percent and percentile. So let us explain. Percent means that I scored 95% in class. That may be good. But supposing everybody else scored 97% and I am the last person in the class, then it is not good. So percentage will just tell you what percentage you scored in class or what percentage of maybe good cells you have or bad cells that you have. Percentile is your position. So if in my class there are 100 people and 10 people scored above me, 90 people scored below me, then I will say I am 10th percentile from top or 90th percentile from below. Usually what happens in the exams, let us say you go for NEET or NEXT, whatever marks you get, they will give you a percentile. So 99.999 percentile is the person who stands first in India. 50th percentile is the person who stands 50th in India. But that patient may have got only 20%, like 20 marks out of 100. That is not counted there. In height weight chart, so the percentile is important because 95th percentile means that the child, if you put that child in a row of children of the same age and the same gender, 5 children will be taller than that child, 95 will be shorter. So usually if the percentile goes below third percentile, then we say that it is short stature. Between third and 97th, we say it is normal short stature. Dr. Gangadhar Rath asks about magnesium and resistant hypertension. Well, actually, magnesium, intravenous magnesium, is a drug of choice in eclampsia, in pregnancy. It helps in reducing the resistant hypertension in eclampsia. In routine practice, perhaps not. If the patient has resistant hypertension, first is to reduce salt intake. Reduce salt intake. We take way too much salt in India and Pakistan. Encourage the patient to take other spices like hing, which is asafoetida, kali mirch or black pepper, lasan pyaz, that is garlic and onion. So encourage the patient to take these spices in the daily cuisine. Also, see if you've added a diuretic or not. Add a diuretic, change a diuretic. That would be the drug of choice of resistant hypertension. And third, stress management. Just make sure that the patient is sleeping well, is not under stress. If you can do these three things, salt, stress, and diuretic, then usually we will not need magnesium. A question from Dr. Gangadhar Rath. Any drug recommended for prevention of type 2 diabetes? Actually, many. So metformin is what we use most often. Acarbose is what has the best benefit. It helps in preventing diabetes and preventing cardiovascular disease as well. This is from the Stop Needham trial. So acarbose 25 milligram TDS, very effective in South Asian diet, especially in people who take rice, people who are orizovorous. Pioglitazone can also be used. and so can GLP-1 receptor analogs. If your patient has got obesity and pre-diabetes and you want to prevent diabetes, then SGLT2 inhibitor like oral semaglutide would be the drug of choice. Dr. Narinder asked, normal triglycerides and role of fenofibrate. Yes, definite role for diabetic retinopathy, even if TGs are normal, and a potential theoretical role for diabetic neuropathy. So Dr. Gangadhar Rath says that why are TG levels below 400 usually not treated? We focus on diet and exercise. We must focus. We should not leave those triglyceride levels. We must focus and we must give a statin. Amongst the statins, atorvastatin has more effect on LDL. Rosuvastatin has better effect on both LDL and triglycerides. So in a patient with TG levels of more than 400, we will start rosuvastatin, maybe 10 milligram. In very rare cases, I will start 20. And we will also focus on diet and exercise. You tell the patient to stop eating ghee. You have to take a pointed history. Is the patient eating paranthas? Is the patient applying ghee on the chapati? How much ghee is visible on the dal or the paneer or the chicken? So you have to ask these. How many times did the patient take butter chicken, cream chicken? So this is something that has to be focused on. We should not leave the levels alone. Non-LDL cholesterol is important, Dr. Vinay. It is a marker of CV risk. The most important marker is LDL. At number 2 comes non-HDL. Non-HDL will include LDL and VLDL as well. So this will in VLDL is representative of triglycerides. So actually in this non-HDL, basically we are focusing on triglyceride level. Dr. Ashok Kumar Sharma says, can we start statins without lipid profile? A definitive yes, sir, we can. In kidney disease, actually the guidelines recommend don't wait for the lipid profile, you just start the statin. In your patients also, you can start statin. If you want a value for your safety, for the patient's safety, then QRIS 3 is a good thing. The patient does not necessarily need to spend money on lipid profile. Dr. Parmar says some people come with below normal creatinine uric acid. This is good actually. So what I tell the patient is, you are doing great. Your kidney is like that of an 18-year-old girl or 18-year-old young man, and then they feel happy. But then we say you have to take good care. You must keep it like this. You must sustain it. GGTP rise in non-alcoholic. This is usually because of fatty liver, NAFLD, non-alcoholic fatty liver. The first line treatment will be diet and exercise, weight loss. If you want to choose a drug, then a good idea would be maybe DPP4 inhibitor or GLP-1 receptor agonist, like injectable dulaglutide, semaglutide, dulaglutide and liraglutide, and oral semaglutide. Dr. Onkar Singh says in non-diabetic patients with dyslipidemia, I'm assuming, how long should we prescribe statin? It is almost lifelong. It is up till the age of 75. But what happens in practice, I've seen, Dr. Onkar, when patient comes to you, LDL is 150, 180, patient does become afraid and patient begins to follow a good diet. Some people will not change their lifestyle. They will need statin lifelong. Others will actually change and they will become very strict with themselves. Then sometimes you can taper off the statins. But above 40, every person with diabetes should get statin unless it is contraindicated. Any person who is at high risk of ASCVD should get statin unless it is contraindicated. Statins are not contraindicated in liver disease and kidney disease. They can be used in mild, moderate, severe renal disease. They can be used in mild, moderate liver disease. If you want a value, you can do lipid profile. And if you're not able to do that lipid profile value, QRIS 3 is good enough. Dr. Girish Gesota says hypertension and diabetes, already on treatment with diuretic. If we start SGLT2 inhibitor, what precaution to take? So number one, tell your patient to take around 300 to 350 ml extra of water per day. That is 1 to 1.5 glasses, over and above what was being prescribed earlier. If patient is on indapamide or thiazide, then you can just add the SGLT2 inhibitor. But if patient is on loop diuretic, that is furosemide or torsemide, reduce the dose of diuretic by half. So loop diuretic reduced by half. All the others you can just continue. Increase water intake by 300 ml to 350 ml per day. Dr. Sanjeev Puri asks about fenofibrate and he points out that the dose is the same. It is 160 milligram micronized fenofibrate or 200 milligram conventional fenofibrate. In the market, usually micronized is available. So 160 milligram fenofibrate. Uh, the dose will be the same, whatever the renal function or hepatic function is. So just give 160 milligram OD with breakfast. Same for bempedoic acid, 180 milligram OD with breakfast. For bempedoic acid, if the uric acid is very high, patient has gout, then it would be a good idea not to start bempedoic acid. First, you correct the gout, make sure patient is asymptomatic and uric acid is well under control. Then you can think of starting bempedoic. For fenofibrate, you don't need to worry at all. So lots of questions and comments coming up. Let us just take one more question. This is a description of the 57-year-old obese patient who has been taking vildagliptin, metformin, uh, triple dose, I think, glimepiride, metformin, and voglibose as well, probably. And earlier patient was on Mixtard 3070, but diabetic levels are fluctuating. Now we are giving actually 4 drugs to this patient: vildagliptin, metformin, glimepiride, and voglibose. So patient is on 4 oral drugs, already obese. So ideally we should restart insulin. Analog insulin may be better. And if the patient is obese and 57, we must start SGLT2 inhibitor. So you can start dapagliflozin or um, empagliflozin, whatever suits you. It would also be a good idea to talk to the patient about stopping vildagliptin, that is stopping the DPP4 inhibitor, and adding a GLP-1 receptor agonist, like oral semaglutide. But the cost will increase by about 300 rupees per day. You should give the option to the patient. So the options here are restart insulin and stop glimepiride. Number 2, add dapagliflozin or empagliflozin. Number 3, stop vildagliptin and add GLP-1RA like oral semaglutide. Number 1 is a good idea. Number 2 is also a good, okay idea, but then you will go to 5 oral drugs. It doesn't make sense to give 5 oral drugs. And number 3 is also a good idea. Even if you give number 1 or number 3 option, you can still add dapagliflozin or empagliflozin to reduce CV risk. So now what we have is either I give insulin plus SGLT2 inhibitor and I stop glimepiride, or I add oral semaglutide and SGLT2 inhibitor and stop vildagliptin. Both these options will be fine. Whatever the patient chooses is okay. I also maybe would take a good GI history, and I might stop voglibose because I don't think voglibose will be acting too much in this patient. Myalgia is quite rare, Dr. Girish, just at the most about 4-5%. If patient complains of myalgia, just look at physical fitness. Make sure that the patient is physically fit and is not exercising too much also. You have never been to the gym before and now you say, I will do 2 hours of gymming every day and I will, whatever in the last 50 years I had not done, now I will exercise in 5 weeks. So stop things like that. Ensure good vitamin D and calcium supplementation. Ensure good hydration. Sometimes the myalgia occurs because patient is dehydrated or has got electrolyte insufficiency. So give good energy drinks. Continue statins. Maybe you might want to change from rosuvastatin to atorvastatin, or maybe atorvastatin to pitavastatin. And usually you should be able to manage these patients. So it's usually not a major issue. If the patient does not respond, you should get a CPK done. CPK, creatinine phosphokinase. If CPK is high, that is myositis, then certainly statins should be stopped. Patient will recover on his or her own. Usually, you will not need to give steroids or admit the patient. And then you can start bempedoic acid as an alternative. Dapagliflozin, okay, so this 57-year-old patient was already taking dapagliflozin. Then certainly we should stop glimepiride and start insulin again. If diabetic levels fluctuate with Mixtard, then no harm in starting analog twice a day or basal bolus regimen for short period of time. We have to tell the patient that we need to control your glucose and we need to reduce some of these oral drugs so that we can bring you back on track. For weight loss, the best drug would be oral semaglutide. So lots of questions that we had today, and I'm happy that we are continuing this discussion. And I'd like to thank once again Team FDC for giving us this opportunity and hand over the stage to them.
Thank you, sir. I know that today was a very busy day and a hectic and a tiring day. So, without taking much of your time, I just thank you for taking such a wonderful session, both here in Chandigarh as well as in our Diabetic Essential with Dr. Sanjay Kalra. Thank you. Good night and Jai Hind, sir.
Jai Hind.